Our first speaker is Dr. Cesar Navarro Carreras, Head of International Medical Assembly. Dr. Nas Carreras earned his MD from Monterrey University in Mexico and completed pediatric and pediatric infectious disease training at the National Children's Hospital. He has attended the executive program and INSEAD in France and received the Latin America diploma in vaccinology at National Autonomous University of Mexico. Currently, he leads the medical affairs of Bosanity Internationalism, which spans Latin America, Africa, the Middle East, Russia, India, and also Asia. He is responsible for developing vaccination strategy, engaging with the stakeholders and supporting the national immunization program worldwide. Today we will speak on the topic, remaining prevention, innovation and strategy for the next generation of vaccination. Please welcome Dr. Nas Carreras with a warm round of applause.
Chairman. And first of all, I want to thank the organizers for this kind invitation. It's my second time in Korea, and I'm really enjoying not only the food and the hospitality of the people, but as well the lectures that we have been hearing, very interesting concepts. And I will try to walk you through how clinical development, pipeline, research goes to one of the most important elements of immunization, which is the implementation of vaccines. As mentioned, I am a Sanofi employee, and I've been working for this company for more than 25 years. And I just want to show you a glimpse of what is Sanofi, a vaccine company that produces or supplies 2.5 million doses of vaccines every day to vaccinate around 500 million people around the world. And we do this in more than 150 countries based on 13 manufacturing facilities in 8 countries. And you can see that a huge amount, a huge percentage of our sales are devoted to clinical development. And why? Because we do believe that there's several unmet medical needs that need to be tackled. So I'm going to present our pipeline, and basically our strategy. We have different franchises, and we have vaccines that have been for a long while with us, and our strategy is to maximize these vaccines, like the one we have for known viruses like influenza, RSV, or the pediatric combo vaccines. We have another pillar of our strategy, which is to expand to new targets, like the pneumococcal vaccine, or new vaccines for other diseases that we are addressing today, like RSV for toddlers, or RSV for older adults, and as well a human metapneumovirus vaccine or combination of flu and COVID vaccines. And we're also, on our third strategic pillar, pioneering in new antigens, new diseases. For instance, for acne as a treatment vaccine, or for chlamydia as a prevention vaccine. So we have one goal, which is to have 8 phase 3 readouts by 28. This is our commitment, and this is where we want to get. So what are the vaccines in our pipeline today? We're working, as I mentioned, in different franchises, either in influenza with the new generation influenza vaccines based on mRNA, or different combination vaccines with our new protein-based COVID vaccine in combination either with our protein-based influenza vaccine for older adults or our high-dose influenza vaccine for older adults. We're also working in pandemic either through egg-based adjuvanted vaccines or mRNA vaccines. We're working as well on a new generation of older vaccines like yellow fever vaccine and rabies vaccine, and as well on the tetravalent or pentavalent combination of meningitis vaccines. In terms of RSV, we're working as well in a live attenuated intranasal vaccine, basically targeting toddlers, and for older adults, as mentioned, a combination vaccine, mRNA-based, for RSV and HMPV. With our partners, with our good partners of SK Bioscience, we're working in the co-development of a pneumococcal conjugate vaccine, PCV21, which proudly we are now in phase 3. And as mentioned before, on the mRNA platform, we're working for 2 new diseases, acne and chlamydia, which, as you know, is the most frequent sexually transmitted disease and an important cause of infertility in women. So, I'm going to give you 2 examples on how this pipeline can be translated to implementation strategies. And importantly, these 2 examples are based on the latest registrations of vaccines here in South Korea. So I will be speaking about 2 different populations, older adults, and this is why I will use the influenza high-dose vaccine example, and then children below 1 year of age, and this is why I will be speaking about nirsevimab, a monoclonal antibody against RSV. So you have heard a lot of influenza. Influenza, as you know, is like an iceberg. The common perception is like a flu-like syndrome, but there are severe consequences of influenza that normally are not seen. And this is mainly seen in older adults. So if we focus on older adults, we can see that influenza has an 8-fold increased risk of stroke, 10-fold increase on heart attack, 8-fold increase for pneumonia. And older adults who suffer from influenza, they can lose in 23% of the time autonomy, and they can have glycemia impact in a huge amount of this population that suffer from diabetes. So influenza in the older adult is not an easy infection. It rather comes with and can come with severe consequences. And this is why the company decided to develop a new vaccine against influenza, which is known as a high-dose vaccine. It's a similar approach as the standard dose vaccine, but it has 4 times the amount of antigen for each serotype. So we demonstrated since more than 10 years ago that the high-dose vaccine has a relative vaccine efficacy above the standard dose for infection in this study of 24%. In other words, when you see the efficacy against influenza on a standard dose, you can add 24% more efficacy for this specific population. However, with this information, we registered the vaccine. It was accepted by the FDA in the United States, and it has been in use in the United States for many years now. But this data was not necessarily accepted by every single regulatory agency, and they wanted to see more, and this is why we conducted several other studies to see severe outcomes when comparing the standard dose vaccine against the high dose vaccine. And there have been multiple studies trying to address this question, but mainly observational studies, which have shown always, depending on the season, depending on the geography, depending on the population, that there is an increased protection when we compare the high-dose vaccine versus the standard dose vaccine in the elderly population. However, we decided to conduct two different trials, which are pre-specified to make a pool analysis out of those two trials in order to have sufficient data to demonstrate that the high-dose vaccine for influenza also protects against severe outcomes. And this is why we developed these two studies. One of them is called GALFLU, which is a study that was developed in Denmark, and that included 332,000 subjects, older adults, in 3 different influenza seasons. And as well, another study which is called GALFLU, because it was developed in Galicia, in Spain, in 2 seasons, and recruited 134,000 subjects. All of them were randomized, pragmatically and individually randomized, to receive either standard dose or high dose. And the idea was to measure the outcomes in terms of severity of the disease. So with this pool analysis of these 2 trials, we developed a new study which is called FLUUNITY, which is designed to demonstrate the benefit of high-dose vaccine against these severe clinical outcomes. Just last week, there was 2 publications on the New England Journal of Medicine of both studies, DANFLU and GALFLU, and next week we will be publishing the results of the FLUUNITY, which is this pool analysis of the 2 studies to have a powered statistical sample size to deliver in these 2 outcomes. So why this type of trials? Well, this is a very robust way to have high quality evidence on the effectiveness of high dose, but importantly on a very specific and randomized control trial, in the sense that normally when we see this type of studies, they're observational studies, and the randomization is a big confounding effect when it's not properly managed. So the other way to see this trial is, importantly, its generalizability, which is taking into account different populations, different regions, different epidemiological seasons, because it's in a period of 3 seasons for Denmark, 2 seasons for Galicia, and adequately powered to understand the differences between both in terms of severe influenza outcome. This is the largest individual randomized influenza vaccine effectiveness study conducted as of to this day. So it's a very important outcome that we're sharing. This, I ask you please not to share this data in advance, because we're still under embargo from the Lancet to share this information. However, I did ask a special request to show you some of these results. And as you can see here, for more than almost 500,000 individuals, this is the beauty and the magic of randomization, that whatever feature you take, whatever characteristic or chronic-based disease in this population, you will have a proportional and statistically equal number of subjects almost in each group. So what we're seeing is a very well randomized trial to understand how these 2 vaccines behave in this population when measuring severe outcomes. The primary objective was to measure pneumonia and influenza hospitalization with secondary objectives of cardiorespiratory disease, influenza, hospitalization, all-cause mortality, hospitalization, all-cause hospitalization for respiratory disease, and all-cause mortality. So we have the first results, and we're happy to share that this vaccine that is now available in South Korea demonstrated a superior protection when compared to standard dose for these specific severe outcomes, which includes hospitalization. So a positive superior protection for pneumonia or influenza. As well for the secondary endpoints, hospitalization for any cardiorespiratory disease of 6.3. For laboratory confirmed influenza hospitalization, of course, a vaccine against influenza will have a very high relative vaccine efficacy against the standard dose of almost 32% relative vaccine efficacy, but also an impact on all-cause hospitalization, which is a very important point to take into account when we're dealing with public health. Because it's different to understand the use of the vaccine, as I was mentioned, from individual health to the impact that could have in terms of public health. And this is where the decision and the decision makers need to take this type of evidence into account in their decision-making process. To make it simple, these are the figures that I've shown you in a very pragmatic way, but I want to focus on the 2.2 relative vaccine efficacy in terms of all-cause hospitalization, because it can give us an idea of what would be the impact of implementing such a strategy. So a 2.2 means that you need to vaccinate around 500 people to avoid one hospitalization for a lower respiratory tract infection or pneumonia. You will say, well, that looks like a small figure. But if you translate that to South Korea, in other words, switching from standard dose to high dose, this means avoiding more than 22,000 hospitalizations. So now we're understanding that even though these are low, we're going from low incidence to highest incidence of events, even a small percentage of relative vaccine efficacy will make a huge impact. And this is why this type of evidence needs to be taken into account, as it has been taken into account in USA and Europe. I think that it's an opportunity for the population of this country to understand how can we improve the health of the most vulnerable population, which are either older adults or the very young. And with this in mind, the very young, I would like to switch to the other example, which is an example for children below 1 year of age. And I'm speaking about nirsevimab, which is a monoclonal antibody that has been recently registered and available here in South Korea. As you know, there are different approaches for RSV prevention. There's a very well-known monoclonal antibody which is indicated for the high-risk population, palivizumab, which is an antibody that has been here for more than 20 years. But recently, nirsevimab arrived, which is an extended half-life human monoclonal antibody, which is licensed for all children entering into their first RSV season. And the reason why is because this is a monoclonal antibody that has proven efficacy for at least 6 months, which is normally in a traditional seasonal RSV, the length of time that the virus circulates, and as well, it had proven to have effect to those children who are not born during the RSV season, but were born before the RSV season and will be entering the RSV season. This is what we call the all-infant protection. Why we call it all-infant protection? Or why do we think that all children need to be or deserve to be protected against RSV? And when I say all children, I'm meaning those children below 1 year of age, those who are entering their first RSV season. First of all, because we know the seasonality. We know that here in South Korea, the virus will circulate between October and March. We know as well that 80 to 85% of the hospitalized children for RSV are previously healthy children. And we know as well that RSV is the first cause of hospitalization. So taking these three considerations into mind, you can easily understand that there is no predictable factor to know which children will be hospitalized by RSV in the next season. So, with a monoclonal antibody that is used on one dose, it is easy to protect the whole population. And I'm going to show you again what does this mean in terms of implementation. I'm not just going to give nice examples, but rather the reality of what happens when you implement such a strategy. The monoclonal antibody nirsevimab proved a high vaccine efficacy of 83% in a trial conducted in Europe, and this was the basis for the registration of the product. But what exactly does that mean in terms of effectiveness in the real world? Yes, it can prevent the disease. Yes, it can prevent hospitalization in 83%, but how can we use it, and what would be the impact of using such a product with an all-infant protection strategy? And I would like to thank Dr. Juan Pablo Torres from Chile for the slides I will be presenting. And this is a study recently published on Lancet Infectious Disease on the summary of what happened in the country of Chile. For those of you who are not completely aware of the geography, Chile is a Latin American country, a South American country, just beside Argentina on the Pacific coast, with a population of around 12 million people and a birth cohort of around 150,000 children per year. So Chile decided to implement the all-infant protection strategy, which is to immunize all children below 1 year of age entering their first RSV season. So what they did is they decided that the RSV season will start April 1st. So children who were born from October 1st to March 31st of the next year, these were to be considered the children born out of season. So all of them, you see, are in the blue bars. They were immunized on what they call a catch-up campaign. So they tried to immunize all those children between the months of April and May. And on the yellow bars, you see the immunization of the newborns. This is why it was steadily for the next 6 months. So they achieved in the newborns, which is an easier target, a 97.5 coverage immunization rate, while for those who were born outside the season, a 90.3 coverage rate, which is very high, because in total it's around 94% of the population was immunized in a very well followed coverage and immunization rates. What happened epidemiologically? Well, the disease seemed to disappear. But you can say, okay, maybe this is because it was an epidemiological year without circulation. The previous year you had a lot of circulation, you decreased the number of vulnerable population, and this is why you see an important decrease in the amount of circulation of the virus. But this is the cumulative incidence of hospitalizations in the non-eligible population. So, you take children who are between 2 and 4 years of age, and in the blue bars, you see the cumulative number of hospitalizations. And in the lines, what you see is the cumulative number of hospitalizations in previous RSV season. So the circulation of RSV in 2024, on the blue bars, it's relatively similar to the one that happened in 2022, which is the purple line, or the one that happened in 2023, which is the red line. So the circulation in 2024 was between what happened in 22 and what happened in 23. So this is in the non-eligible population. So what happened in the immunized population? Practically no disease. It's an important reduction in the number of hospitalized cases. The impact that the monoclonal antibody had on the disease was measured with a very, very good and very strict surveillance system. And you see that from this view, you can see that around, I don't know, it's between 80–90%, something like that. But what they made even more proud, the programmatic administrators of this strategy, was to see that there were 0 deaths, no deaths by RSV in the country. So can you imagine just avoiding the deaths of a very specific disease? And I can tell you, the Minister of Health in 2023 was fired because of this. And you know health authorities that are here, that having such a crisis sometimes will deal with the opposition. So on the contrary, this meant that many people, when successes like this happen, they say that failures are orphans, while successes have a lot of parents. So now everybody was being proud that they were the ones who decreased the mortality to 0. So in practical terms, the effectiveness of the intervention in Chile in terms of hospitalizations for RSV, 76%, intensive care unit hospitalizations, 85%. And look at the bottom, please. All-cause hospitalization, almost 50%. They decrease all-cause hospitalization 50%. Whatever type of hospitalization, just with one strategy and one intervention. So, depending on the year you want to compare what happened in Chile, you can have from reductions from 80 to 95% in terms of hospitalizations and 0 deaths. In the coming months, they will be presenting the cost, the pharmacoeconomic analysis. And I can tell you, because it has been shared, that for every US dollar they invested on the program, they saved not only the dollar that they invested, but 45 cents above that. In other words, this type of intervention is a cost-saving intervention that not only decreases the hospitalization, saves lives, but at the end, it's also an investment that saves money. Importantly, as you can see in the bottom, the number needed to vaccinate to avoid one hospitalization is between 35 and 37. And this is why you can understand that it's a very cost-effective strategy. And this is not only exclusive for Chile. In every single country that have implemented a program and had the ability to measure, you see this similar numbers in terms of impact. This product has been registered now in more than 50 countries. There's more than 7 million children who have benefited from the monoclonal antibody, and either it's the US, Spain, France, Italy, Australia, you see similar numbers in terms of a very high efficacy to prevent lower respiratory tract hospitalization, and of course, in some cases, also preventing deaths. So with this, I thank you very much for your attention, and I think that we are in front of huge opportunities to consider in our environment. Thank you.